for these lectures for the last 5-6 years. So it's my pleasure to introduce today's speaker, who was another one of our esteemed residents. So, as you know, this lecture series is in honor of Dr. Alexander, who unfortunately could not be here. He's on Zoom, so he should be listening to us. Dr. Alexander also worked here most of his career. He came in 1979 and he retired in 2016. He was very well known nationally. He was our program director for many years. I was a resident from 94 to 97, and he was had been our program director since 1990 until he retired in 2016. Dr. Kathrina took over. He was also section head of autopsy, and he also worked in the coroner's office. He was also forensic pathologist. So he was an ACLIPS, which is the Blood Medicine Society president, got awards here, ASCP president, and also the only pathologist president of AOA, which is the Medical Honor Society, as you know. So I thought I would share this with you again. Many of us are still here. We trained with Dr. Alexander. I'm the oldest one of this group. Then Wally and I started kind of together, and then Ginger and so on and so forth. You see that. Several of them are in Montgomery, so you may not see them, but you know their names. And then several of them are at Children's, and most of the time they attend these. And the most recent one is Liz Staley. And Brandy, I fixed the order because I had made the mistake last time. I looked at it and said, there's something wrong with it. I just thought I would very briefly review with you the last 3 speakers we had, which by chance were all women. Doesn't mean he only trained women, but maybe this means something. I don't know. I'm just kidding. No, absolutely no reason. We all were very happy to welcome back Yara Park, that's at UNC, and then Amy, who is down the street, did an amazing job as a chief of college at Children's. And last week was Sarah Bean, who is at Duke, also left UAB, went to Duke, never left. But today we're we're welcoming somebody that has had a very international career. So this is a picture of Kathrina here in the second one with a group of residents. The person next to her, this is not a great picture, is Emily Reisenbichler, and she was here in February giving grand rounds. So we'd like to bring residents back. So Kathrina went to medical school at University of South Carolina, like Caroline and others. She was here for her residency and then a year of hemopath with Dr. Reddy, who has trained half of the hemopath people in the world. She was Search Path Fellow, and then she went to Missouri. But first of all, these 2 pictures are from the residency graduation in 2010. Xiaowei Li, who is with her in that picture, is at MD Anderson as a full professor of hematopathology as well. And in this picture, you may recognize Amy Treese and Kathrina and Frank, and you may recognize Jason, Daryl, and Dr. Sito is in the background, trying not to show up, but there he is. I'm there in the middle. So Kathrina has a very interesting career, and I think that's what we're going to hear more about it. But as I said, she went to Missouri. Joplin, Missouri is where a tornado went through in about 12 years ago, 11 years ago. So that's how Joplin was famous, I guess. Yep. Then she went to Germany. Then she came back to Arkansas. Then she went to Edinburgh, and then she came back to the States, and now she's in England. So it's going to be a very interesting hour for us to hear. If you're interested in knowing a little more about her Germany excursion, she did an interview, which I found online, to something called in Hippocratic Adventures, and explain how she ended up in Germany and how it feels to be an American pathologist in Germany. It's a very, very nice interview. Now she's in this little town between London and France and Belgium, and not too far from the other Birmingham, but pretty far from this Birmingham. So yes, we are very excited to have her, to welcome her back to UAB. And the title of her talk is Pathology Through a Different Lens. So Trina, what's up?
Thank you so much. Well, I should start by telling you guys that Marissa was, might have to turn that down a little.
That's not working. We're gonna have to, well, I can do it real quick.
This is.
No, the clicker. Hold on, let me get the.
I should say that one of my greatest mentors was Dr. Marcus. And you guys are so blessed and so fortunate to have her here. I tell my young trainees in the NHS all of the time, because I have trainees there. I tell them all the time, especially the women, admittedly, because there are differences in how women and men are received in professional circles. It's simply a part of life. It's just honest. And so I tell them all of the time, when you're hitting your 30s and you are a professional woman, if you can find a woman mentor who can help guide you through it and be your professional mom, grab a hold of her and do not let go, because they're very hard to find. Especially, with each generation, I think it gets a little easier, but I know in my generation, it wasn't easy to find. And you have always been an absolute treasure to me. So thank you. So clearly I'm the little A. I'm not, I trained under Dr. Alexander, but he's the big A. And I'm the little A. We are not related. Although if we had been, maybe I would have got some of his height. That might have been nice. These days I'm continuing to grow, but probably not in the correct direction. So we're going to try and just walk through this morning. Which one should I use to advance? I can use this? Okay. So I want to talk to you today about the different lenses that we can use, just a few of them, understanding that this is going to be a small fraction of the realm of possibilities that exist. And this is meant to encourage you to see more, not to limit you. Consider this a taster course for an absolute smorgasbord of possibilities. What I want to do is encourage you to see more. Okay. So a few things to get out of the way, a couple of disclosures. I have had various and sundry financial relationships with various different business and pharmaceutical entities. And as an employee currently of IQVIA Laboratories, which along with LabCorp, they are the world's 2 largest contract research organizations. And so through my work at IQVIA, I have affiliations with most pharmaceutical companies that exist. So understand that is my perspective. I am also the chief executive officer of a limited liability company called Pillar Strategic Solutions. All opinions are my own, and I have plenty of them. So as pathologists, as we're a self-selecting group, we have a tendency to see the world a little bit differently. We often are a little bit of a different kind of bird, and I even more so. I am a weird bird among weird birds. So let's just get that out of the way right away. Okay. I'd like to say that I'm lovably eclectic, and if you disagree, feel free to humor me in my delusion. But we like to see things through a unique lens, and perhaps that's why the microscope suits us so much, because it permits us to honor our need to see life through a slightly different lens. I've always been a bit of an out-of-the-box kind of person, but I'd like to think that that's a good thing. Throughout history, many of the best innovators and creators who have brought positive change to the world have been just a little bit different. And so I would like to encourage you to blow out the walls of your box and join me on the crazy tour, okay? So, because only the people who are crazy enough to believe they can change the world can actually do it. And you have to hold space for that possibility. So use your superpowers for good and come change the world with me, okay? All right. So we make jokes about pathologists being a little bit different, and it seems like a trivial little joke, but it's really not a trivial matter. The fact of the matter is there are studies that demonstrate that we actually are a little bit different. As IQ goes up, there are certain characteristics and traits that have a tendency to accompany high IQ. And I like this paper, even though it's not in our traditional pathology literature. I like this paper because it talks about the other kinds of characteristics that tend to accompany high IQ. It's not just a comedic trope. Sheldon really likes his routines because Sheldon is brilliant. And the flip side of the coin of brilliance is that there are certain needs for structure, OCD, autism spectrum disorders, they go together. Leonard, like me, is always reaching for his inhaler because these things go together. So let's take a little bit more of a look. I really love this diagram. I keep thinking this diagram should have been the caption under my high school yearbook picture. The diagram didn't exist at that point in time, but I live in the middle of this diagram, and a lot of us do. One of the hypotheses explored in this paper is that there is a hyperbrain, hyperbody connection, that the very same attributes that confer that high IQ, that make us more aware of our surroundings, that make us more hyper attuned to our surroundings, those things result from a hyperactivity neurologically. But like most things in nature, there's a mind-body connection. There are parallels for that within the body physiology as well. It's not just something psychological, right? Those of us with high IQs, and most of the people in this room, let's be real, we're a self-selecting group. I would imagine all of us are in this group somewhere, right? There's another study that says that all persons with IQs over 140 demonstrate autism spectrum traits, right? And I don't know how accurate it is, but in personal experience, I'd say there might be some accuracy to that. But a lot of us live here in this diagram, right? Those same things that make us hyper attuned to our environment, that are adaptive in some contexts, right? That help us to understand patterns in tissues and in laboratory tests and in patient presentations that confer increased odds of success in our career fields also lead to these things. We have a tendency to perseverate. We have a tendency to be perfectionistic and to demand absolute perfection from ourselves and from others, be a little rigid and unforgiving, just like Sheldon. I need everything to be, linear and rigid. But at the end of the day, we also ruminate more. We worry more. We develop mood disorders. We develop anxiety disorders. I live there, right? We also, as it happens, seem to have a physiologic parallel to this. Our bodies, in response to stressful stimuli, will secrete higher levels of cortisol. We all know that's not great, right? That has some physical and physiological implications for our health and well-being. In addition, we generate higher levels of cytokines, inflammatory cytokines, driving inflammation in our bodies. And that's why we have a higher incidence of allergies and asthma. 2 ICU admissions for acute asthma exacerbations. I told you I live here, right? Autoimmune disease, autism spectrum disorder, and neuroinflammation. When our trainees come to us, we have to first recognize that they are human beings. And just because they put on a white coat does not mean that all of this went away. So you may not be able to see it, but bulging out from under their white coats, they have all of these things. I certainly did, right? I had anxiety. I've got some autism spectrum traits. I mask very well. I do the cheerleader thing. It works. Doesn't work so well in other cultures, by the way, which is one of the reasons I like other cultures, because I don't feel compelled to mask, right? Because I couldn't if I tried. I don't understand the cultural context. So now you understand why I'm a wild and crazy world traveler. Autoimmune disease is something that I live in. And again, those anxiety disorders, you will be able to see that later on. Whenever we're interacting, I have wicked social anxiety, but the cheerleader works. Okay, keep going. So what does that have to do with anything? Well, I want to remind you that the first lens we need to apply to our trainees and residents when they walk into the door is we need to apply a human lens to them. We need to remember that they are human beings. And, even though we like the microscope, we need to not forget the very human people standing in front of us. And, if you would, do a little exercise the next time you bring in a resident class and visualize them with bags under their white coats, because that's what we've all got when we walk in the door. I had tons of baggage when I walked in the door. And if we want to get our trainees, I see Stephanie, if we want to get our trainees over the chasm to competence, we have to meet them where they are and bring them to where they need to be. But we have to start by acknowledging that they come to us with some baggage that they might need some help carrying, or figuring out how to add on the skills necessary to achieve competence onto their already burgeoning plates. And that's the first thing that we owe them. We have to remember. And I'm going to start here. This is the world in which I live, right? So I'm going to talk about this. And I think you've all figured out, I'm going to talk a little bit about my journey. Allergy and asthma, 2 ICU admissions, and then autoimmune disease. So when we talk about different lenses, we are all trained doctors. The rest of the world may not realize we are trained doctors, but we are trained doctors first and foremost. And so we are very skilled at using the clinical lens. So let's look at a single patient case, and let's look at it through a couple of different lenses, because the different lens that you use lends a different perspective. And keeping in mind, as you're going through your career and your life and your daily work, remembering the different perspectives involved is helpful. So we've got a 5-year-old Caucasian child. She's hyperactive, but she comes in, her mom brings her in, and she says, she's just not acting quite right. She's really tired. Her joints are hurting all the time. She's got ulcers in her mouth and a really pesky one in her nose. She's got rashes everywhere. But in particular, she's got this rash on her face that lights up bright pink in sunshine. Why does it do that? She's in growth arrest, and her BMI is 11. So what I posted here on the right is the SLIC classification criteria for systemic lupus. You can use any criterion you want. They all look like this. They are wicked complicated. It is very difficult to make this diagnosis. And it's a trope that we see on House all the time, right? At the end of every differential diagnosis is lupus, right? Lupus can look like anything. It's the disease of 1,000 faces. And in this case, it happened to have a butterfly across the face of a 5-year-old. All right. So this 5-year-old child has systemic lupus, but it's not an easy diagnosis to make. We're not good at making this diagnosis. And the process to diagnose these children is wicked invasive, right? It involves all kinds of needles and all kinds of really not pleasant places. It involves lots of high volume blood draws, right? 19 tests. I think this child had 19 different laboratory tests that were ordered at the initial diagnosis. Imagine drawing 19 blood tests from a 5-year-old and the volume of blood, right? And the transfusions they're going to need by the time we're done, right? So it has we need a better diagnostic algorithm is why I say that. Okay. So now let's look at this, let's shift lenses and let's look at it from the perspective of the kid, right? So you can't see it up close, but this child has a raging malar rash across her malar eminences. It's bright pink, and it turns vermilion in the sunlight. And she's 5 and she's bouncing around in the office and she's tall and she's really skinny. Unlike me, I do not have a swimmer's body. This child definitely does, BMI of 11. But she's profoundly fatigued and she's coming in saying, I'm just tired. And she says, my wrists hurt. And, she's tired of all of these rashes because her friends make fun of her because they don't know what this means. And they're playing on the playground and they don't want to be around her because their mommy is scared of the rash on her face. And she's got these aphthous ulcers that are irritating, especially the one in her nose. And she stopped growing. She used to be the tallest in class of the girls. And now the other kids are passing her. And she doesn't like that. Let's look at another perspective. So the mother comes in and she reports, I don't know what to do. We've been to a couple of different doctors and she just comes home to me and says, Mommy, I don't want to play. I don't want to play with my best friend. I just want to go to bed. And then the episodes where she's having abdominal pain that is so intense that she's on all fours on the floor with tears streaming down her face in excruciating pain. And people keep telling Mom nothing's wrong. And Mom says, well, I understand I'm neurotic, but there may be more to it, don't you think? And I don't want to eat, Mommy, especially not meat. She's made herself a vegetarian and she doesn't really understand anything about the social ramifications of meat eating. She's not old enough yet. She's got an altered mental status. She's just not herself. The school nurse calls her mom the other day and says, Mom, I'm not sure what's wrong, but something's just off. And the mother thought that the child was just acting up and said, I'm going to go up there and I'm going to spank that child. And She gets up there to pick up the child, and she realizes that the nurse is right. And she doesn't have words to put it into either, but something's just not right. She's just off. And the child's sleeping, but it's an unnatural kind of sleep, right? Altered mental status. Her mother had donated clothing from the child to other classmates earlier in the year because the child was one of the tallest kids in the class, but the other kids that year had done their 5-year growth spurt, and this child didn't. Right, so those donated clothes came back to mom, and that's one of those things that lit it up for mom. And she said, I went and checked the giraffe on the door frame, and the line hasn't moved in a year. All of her friends have grown a couple of inches, but her line hasn't moved. Giraffe has not had change. Her eyebrows are falling out. We went to get on a cruise ship the other day, and they didn't let us board because she has this rash on her face, and they were afraid she was contagious. These are the real stories, right? These are the real things that patients and their families go through. Mom is anxious. She's afraid. And then the real kicker, she's me. I know you did. This is my daughter. This is my story, right? Most painful chapter of my life, single mother in medical school. But I'm just neurotic, right? There's nothing wrong with my kid. Malar rash on her face. In this picture, see, it's right there. Right there, sparing of the nasal labial folds. And then they accused me of Munchausen by proxy. To which I said, wow, I think you must think I'm incredibly brilliant because I don't know how you fake this. Like, dude, how do you fake that? That is not lipstick on her cheeks. Facial biopsy showed immunoglobulin and complement C1q deposition on immunofluorescence of the lesions on her face, showing discoid lupus. Renal biopsy showed the same with mesangial-proliferative glomerulonephritis. Creatinine clearance was 29. Back then, that's how we measure things because I'm old. and at 20, we start ramping up for renal transplant in children because they do not do well on dialysis, right? So these are the real stories. This is what we're here for, right? It's easy to forget when we're just looking at the glass or when we're just looking at our student who's off and they're falling asleep at the microscope today, and why? Why are they having this moment, right? This is why, because when our students come to us, they have all of these competing demands, right? And they bring all of that with them to the microscope. When they sit down across from you to double head, they're thinking about their mother who was just diagnosed with pancreatic cancer and their husband or their wife that is having a rough week at work, or somebody who just all of those things. They're worried about how to keep the electricity bill paid and keep the lights on. What am I going to feed my kids for dinner tonight? Or can I have a baby? I went through that. Secondary infertility while I was here, 10 miscarriages while I was here. A couple in the second trimester. So when they come to us, this is what they've got. They're living at this intersection of all of these incredible colliding forces, and they're right in the middle of the maelstrom. And we have to remember that if we are going to bring them to competence, we have to remember that we have to bring all of these colliding priorities with them through to the point of competence. Different lens. We have to get them over the chasm with challenges. There's not a bridge. Well, clearly I made it, right? This is my daughter and I at my med school graduation. I was a single mom. I had no family support. I'm effectively an orphan. My ex-husband was in the military, so we'd moved around. Wonder where I got that bug. We moved around a lot, so I didn't have any community support either. But we managed to get through it. And part of that was you, right? Part of that was you because you helped me jump that chasm, carrying all of the weight that I had to carry. My daughter's doing well now. She's 26. She's an international lawyer. I think she's doing all right. She looks like she owns the cover of Vogue. She's certainly more stylish than I am. We didn't start off in a very good place. A quick Google search will tell you these words, which will make any mother's heart stop. Pediatric patients are much more likely to die in the acute phase of the illness because the earlier the age onset of systemic lupus, the more severe the derangement in immunoregulation, right? And there are more life years to accumulate and organ damage, and they start sooner. And so all of those normal developmental processes get deranged. It goes off road, right? So where did I get the idea to go off road, right? Well, I think I was always meant for it. So again, that incredibly complex diagnostic and treatment algorithm for systemic lupus. So we found ourselves somewhere about here, right? So we've gone through all of this treatment, all of this diagnostic labyrinth, and we finally get to the point of now we're ready to treat. After we've had a Munchausen by proxy allegation, and we've been locked in a video room, I kid you not, in the hospital so they could repeat all of the testing while we were on video. How do I know this? Because I did my medical school at that hospital. These were my attendings. Joy, right? My attendings. That was hard. Hardest chapter of my life. This is the real deal. And by the way, pathology is a small world. We are all going to still see each other. In 10 or 20 years, no matter where you go on this planet, I'm going to see you at a conference. I'm going to see some of you when you come on vacation, whatever. We're going to run into each other. It is an incredibly small world. So be careful how you treat each other. Second point. So we got here to the treatment phase, right? And so we've got organ-threatening disease. So we're here, right? So first-line therapy, high-dose glucocorticoids with secondary with secondary agent. Secondary agent was Plaquenil. That's great. That's fine. That's pretty benign. You would think a little bit of steroids, right? A little bit of prednisone, no big deal. 0.5 to 1.5 milligrams per kilogram is the therapeutic window for maintenance therapy in systemic lupus treatment, right? So the doctor, Dr. Skarjan, politely prescribed 1.5 milligrams per kilogram of body weight for my beautiful child. And she promptly developed intractable epistaxis, altered mental status. And when I brought her home after the nurse had called me to say something's just not right, she's off. And I thought she was acting a fool. So I went up to the school and I was like, I'm going to put that child in her place, right? Because I'm one of those mamas, I am. And I came up there. I love my daughter to death. You know that, she's spoiled to death. But I'm hard on her, I am. And when I got up there, she was asleep in the nurse's office. And it was just wrong. I can't tell you what it was. It was just wrong. She wasn't sleeping right. She had altered mental status. And I took her home. We took a nap. It was Valentine's Day. And I was wearing a white sweater. And when I woke up, I thought she had drooled on my arm. And my white sweater had a big pool of red, an expanding pool of blood. And I could not get the epistaxis to stop because she had malignant hypertension. Right. So we can't use first-line therapy anymore. Now, back then, we didn't have mycophenolate really in place yet. So the next thing in line is pulse cyclophosphamide. And you've all ever had the prospect of giving pulse cyclophosphamide to your kid? Your prepubescent little girl? Fun fact about pulse cyclophosphamide, it causes premature ovarian failure. So my 6-year-old would never have, she's now 6, would never have gone through puberty. She would never been able to have children. I want a crown. Okay, I've earned that. But she never would have gone through puberty. So this didn't seem very palatable to me. So we really needed another option. We needed another lens, right? I need another lens. I am desperate. I don't want to bury my child because these children die. So I needed some hope. So a long time ago in my previous life, I had worked for the National Science Foundation at this place, the Mount Desert Island Biological Laboratory. And I love this place. It's up on the coast of Maine and Bar Harbor. Right out there, these little shanties on the cliffs of Frenchman Bay that have like $500,000 piece of equipment inside them. And when the wind blows, with the windows closed, everything rattles, right? Fantastic place. And there I worked for this man. This is Franklin H. Epstein. So Dr. Epstein was the William Applebaum Professor of Medicine at Harvard for a very long time. I don't even know how long. And he also was an editor for both New England Journal of Medicine for 15 or more years and an editor for Harrison's Principles. He was also my friend and a colleague. So Frank was a world-renowned nephrologist who had 400 papers almost in high-ranking peer review. I mean, he was brilliant, but he was also an incredible mentor and an incredible teacher. And Frank had taught me during our time at MDIBL working on this, on CFTR, on cystic fibrosis transmembrane conductance regulators. We were working on the rectal gland, a salt gland, in elasmobranchs, which can go back and forth between salt and fresh water and brackish water. And the reason they can do that is because they have this salt gland that has a ton of CFTR in it. Right. So he was studying fluid and electrolyte homeostasis and balance. Of course, for a world-renowned nephrologist, that's a good thing to do. But he did a lot of the seminal work on CFTR. But what Frank really did was translational medicine. And to me, Frank will always be the father of translational medicine in my mind. And Frank had introduced me to this concept of translational medicine, of taking scientific discoveries from the very, very front of the bench and trying to play tug of war with them to close the gap to the bedside and bring them to the fore of patient care in order to help patients for whom there wasn't another good option, right? He also did signal transduction, cascade, biochemical elucidation, right? So when there are black boxes in the biochemical cascade, he would do different kinds of research to try and figure out what went in the black box. And then he would try to do extra work on it to see if there were any agents, agonists or antagonists for different parts in the pathway that he could use in order to target actionable targets in the pathway to work around breakages in biochemical pathways that happen in disease, right? That form the foundation of disease. Just like CFTR is defective in patients, it's mutated in patients with cystic fibrosis. So what do? You try to find some other point in the pathway where you can intersect meaningfully with some kind of chemical, drug, agent, therapeutic to get things working again. And Frank encouraged me to apply this lens to my daughter's problem because I wanted to crawl under my bed and hide. The only thing in the world I wanted was someone to make it better. But there wasn't anyone who could make it better. There's not a good treatment for this, y'all. 1 in 4 million children who are 5. 1 in 4 million children. That's my kid. No good treatments for it at this point. I'm looking at premature ovarian failure, permanent infertility, and that still wouldn't guarantee that the glomerulonephritis would resolve. Studies do not, it doesn't work. It kind of shuts down the rest of it, but the kidneys still tank. Okay, so wasn't a good choice. So I decided to take Frank up on it. So I stepped into the world, at least in my mind, of translational medicine. So translational medicine has been described as the interdisciplinary branch of the biomedical field supported by those 3 main pillars that we talked about, the bench side, the bedside, and the community. And the goal of translational medicine is to combine disciplines. It's collaborative. You have to reach out to other people who do other things, and you try to bring everybody's skills together in one big pile to see if you can find an answer, right? That's what translational medicine is. Pathologists are uniquely suited for translational medicine, right? Because we are the connection point between science and medicine. We are where translational medicine homes back. We are its rightful home. And so I came back to this problem and started looking at it through this translational lens. All of these things, the autoimmune disease that my child has, I started examining this through a translational lens, and it made me do a lot of research. I had to go off-road, and I became a bit of an armchair expert, and lots of people thought I was crazy. I probably sounded like a maniac. I probably was a maniac. It's all good. But the reality is, I just didn't want to bury my child, and I started developing some hypotheses about how immune regulation worked and how it was broken potentially in patients like my daughter. So I started thinking about the immune thermostat. And gosh, I wish it was this simple, because it's not this simple. There's not just a button you can push. We don't understand immune regulation, or at least we didn't at that time. My daughter's 26. She was 5 and 6 at this point in time. So we're talking 20 years ago, which is a long time. It looks more like this, and this is a really easy diagram. Immunoregulation has 1,001 feedback points. It's got all of these feedback loops with super enhancers and loops and coils and all kinds of dose-dependent steps where if you give high-dose prednisone, it does one thing, and if you give low-dose prednisone, it does another thing. And this is what I started tackling into. And it's wickedly complicated. But I wasn't the only one who was looking at this, because clearly it's a problem, right? At the same time, in the same era, a molecule called PD-1 was discovered, and it was discovered at Kyoto University in Japan. Who was it today? I thought it might have been you. I was thinking of this whenever I talked to you. At Kyoto University, a team of scientists discovered a molecule that they called PD-1, which stands for programmed death 1. It is an apoptotic activator situated predominantly and discovered predominantly on T cells that program cells for apoptosis, right? To die off, to turn down. It is a dampener of immunity. It turns down the immune thermostat. Okay, this was an immunology discovery. And you go through this whole series. It was actually discovered in the early 90s. And in the late 90s, it was characterized. And then in the early 2000s, we were starting to fill in a few of the black boxes in the cascade, but precious few. And at the same time, it began to be applied in oncology because that's where the money is, right? And that's where the need is. So the work tends to focus on the area of need and where funding can be secured. That's oncology. So it began to be applied in oncology. And it was found that tumors can sometimes express the programmed death ligand 1 and programmed death ligand 2, the molecule that attaches to this receptor on the surface of the T cells, and it turns off. It turns off immunosurveillance. It causes the T cell to die, right? Whenever it's bound to PD-1 or PD-2. And tumors could use this to shield themselves. It was a cloaking device that tumors could use to shield themselves from immunosurveillance. It's like on Star Trek or whatever, where you turn on cloaks. PD-L1. No. Is it Harry Potter? Okay. Well, the invisibility cloak of Harry Potter. I love that. That's fantastic. In the land of J.K. Rowling. So, okay. So if you block PD-1 or its ligands, you could turn back on the immunosurveillance, it was found, and have an increased tumor killing capacity. We turn back up the immune thermostat. So this is the face of the man whose work I hope will eventually change my life and will change my daughter's life, or maybe my granddaughter's life, or my grandson's life. I was looking for this man for 20 years. And this man's name is Tasuku Hancho, and he was at Kyoto in Japan. And he is the one who characterized PD-1, this molecule. I had come to understand that there was an immune switch in my daughter that was broken. When she would get an illness or an infection, her immune response would mount, but then it would not turn off at the end. And immunity has a tendency to build on itself like a snowball, right? It's this crescendoing. And if you catch it when it's down here, you can interact with it pretty easily with low dose measures. But if you wait until it's a snowball and you're developing antiphospholipid antibody syndrome and DIC, it's too late. I don't care if you hit it with a nuke, it's not going anywhere. So these were the things I learned about autoimmunity. People thought I was crazy. They gave him a Nobel Prize. I mean, clearly I didn't say this right, but he did characterize it. So I got to keep my daughter. He got a Nobel Prize. We're good. But he discovered then he received a Nobel Prize in 2018 in physiology or medicine, along with Dr. Allison from MD Anderson, who discovered CTLA-4, which is a much bigger switch in the biochemical cascade. Anyway, he made what's important for the purposes of our conversation is that he made his discovery by studying a cohort of atypical lupus patients. He was studying my daughter and me. So we both have atypical lupus. Take my plaque when you every day. So even though these discoveries were in the field of immunology, they've been applied in oncology with incredible effect. Let's see. These discoveries also have a great deal of potential for autoimmune disease, and I've been waiting for 20 years for this to home back to its home, and it's finally starting to. We'll get to that in a minute. One of the things that made this field explode was that in 2015, a friend of mine, actually a colleague of mine, had some men in black suits show up at his office, and they had a paraffin-embedded tissue block in their hands, and they were reading off of a piece of paper, and they told his secretary, we need this tested for PDL1. And the pathologist, the receptionist called the pathologist in, my friend, and he said, well, can I get any history with this? And they said, no. Okay, then. So he had an H&E cut, and he looked at it, and he said, okay, this looks like brain. And it's got a metastatic malignant melanoma that is melanotic. And by the way, it is diffusely positive for PD-L1. And so Jimmy Carter was placed in some of the earliest trial uses of pembrolizumab because his brain metastasis of melanoma was PD-L1 positive. And Jimmy Carter, as many of you may know, he just celebrated his 100th birthday just before he passed away on December 29th of last year. He was our first president, American president, to reach the age of 100 years. And he lived 9 years with stage 4 metastatic melanoma in his brain on pembrolizumab. I think that's pretty incredible. But, so the entire world began to get on this bandwagon because this was an innovative discovery. This was a brand new lens, right? This was a brand new way of approaching cancer, of approaching oncology. And so the world of immuno-oncology absolutely exploded. And I watched as all of the funding, the research funding that was floating around in the stratosphere for pharma, it all got sucked into the black hole that was immuno-oncology. Everything else evaporated. And so I decided to join the bandwagon. About the same time in 2017, I got a recruitment call. I was target recruited by a pharmaceutical company, a CRO actually, in Kassel, Germany. And the CEO flew to the States and I met with him and we agreed that I would come and join him and I would travel and teach other physicians about how to interpret PD-L1, what the pathway was, how all of this worked. And so I did. I went to Germany. I learned German, at least passively. I'm not very good at it. German is very difficult, but I learned it while I was working and my family went with me. And I was having a terrible midlife crisis and I decided that instead of buying a sports car, I'd just move to Germany. So I sold my horse farm and then I sold my other house and my other house and I sold my 3 cars and we moved from a 7-bedroom, 4-bath house in southern Missouri to a 1-bedroom apartment in the middle of Kassel, Germany. This beautiful place you see here. That's the Bergpark Wilhelmshöhe with Hercules, who, by the way, is doing a full Monty. So I'm glad that this is not close on top of the mountain here at this UNESCO World Heritage Site, which, by the way, I could see from my office window. And I started reading for clinical trials. And I decided I would just take the leap into the world of translational pathology. So translational pathology is an interesting world. It ties into translational medicine as a whole, which has multiple phases, which are depicted here. You got the scientific discovery phase done in the laboratory by hardcore PhDs who are brilliant and incredible, and they're elucidating signal transduction cascades and identifying those actionable targets and developing the drugs that may work to either stimulate or inhibit those pathways. Right, then you translate that into humans. You know, the T0s are usually in animal studies or in vitro. Then you translate it into humans in vivo, and those are your phase 1 trials, right? And then come your phase 2 and your phase 3 trials, which are the efficacy wings of clinical trials. And then you go for FDA, European medicines, CFDA approvals, and then it rolls out across the globe. In number 4, your post-marketing, your stage 3, your T3 here, is where you're watching the drug while it's being used around, in populations to make sure that there were no unforeseen side effects, no unforeseen interactions, and no unforeseen extra bang for your buck because pharma would not like to leave that laying on the table. Let's just be real. So that's what's happening in phase 3, in T3, and in T4, then it gets extrapolated out and expanded across the globe. You start with small populations that you tested and then you extrapolate outward. So I joined this. And I've done all of these things. I could talk for days and days about the different things that I've done in here. In making, changing the way that we classify disease, figuring out what patients you should treat, right? Am I going to, in trial, I'm going to tell you about just here in a minute, we were able to identify the patients who had a CPS, a combined positive score on PD-L1 of greater than 10. It predicted a survival improvement in event-free survival in the treatment group. It was something like 38% predictive value. I don't even remember. I've got it written down. At any rate, we could talk all day about this, but for the sake of time, I think we're going to move on. But I don't think this is probably more of an accurate map of the kind of ways that translational pathology can be applied in the real world. And I'll give you a couple of examples of things. Molecular biomarkers, figuring out that there's a blood test that I can give somebody so that I don't have to put them through that wicked diagnostic algorithm that we saw earlier. That would be a biomarker type of development. Multi-omics, we developed a spatial mapping program, a computational AI spatial mapping program that can map the spatial microenvironment of tumors, and then we can layer multi-omics data on top of it, proteomic data and genomic data, and start digging into the microenvironment of tumors to see who's really interacting with who. And why does that matter? Well, you can be in the same room, but that doesn't mean you're talking with each other, right? I mean, if you're sitting there and you're sitting there, you're probably not talking. But if you're sitting right here, you're probably talking. All right. So we use a lot of, I have done quite a bit with artificial intelligence. I am the global director of companion diagnostics down here on the right-hand side, which is where you're using a test to predict what patients you should treat with a particular drug and you use the biomarker as a gatekeeper to decide if the patient gets treatment or not. I do a lot of that. We'll come back to it if we have time. So I want to give you an example of a recent trial that I've had close out. I do a lot of clinical trials. I do several hundred clinical trials all around the globe. And I am actually the only hematopathologist who reads our trials for Europe, Middle East, and Africa for IQVIA, because there's a shortage of hematopathologists in that part of the world for reasons Dr. Reddy and I were discussing earlier. Anyway, the Keynote 689 trial is a phase 3 randomized open label trial for patients who have resectable head and neck squamous cell carcinoma that is locally advanced. There were 734 patients from all 3 market sectors, meaning Americas, EMEA, and APAC, right? Those are the 3 main market sectors. And we had 734 patients, and we divided them into 2 arms. We had a control arm of 351 patients who received surgery and standard of care. Standard radiotherapy plus minus a platinum-based agent, depending on their stage and their margin status and that sort of thing. Okay. And then we had the study arm. This trial is important because it is, in the past, trials with immune checkpoint inhibitors utilized in the context of squamous cell carcinoma have been a colossal failure up to this point. Quite frankly, it's been very disappointing because there had been no major breakthroughs in the treatment of head and neck squamous cell carcinomas in this category for more than 20 years, right? We just stalled out. We were dead in the middle of the road. And then the idea came from the principal investigator of this study to give pembrolizumab 200 milligrams in a neoadjuvant context, resect, and continue to follow the entire normal standard of care based on whatever stage the patients were at, and then follow up with pembrolizumab maintenance therapy after the point of resection. Right? So you're hitting a double hit with the immune checkpoint inhibitor. This is important because when you first hit the patient in the neoadjuvant context, they've got all of this. That's when the primary immune shielding may be active, right? And so you've got a lot more tumor there where you have a greater potential for activity of the drug. But in the post-surgical context, you've only got a few residual cells, but there's no way to chase those with a scalpel. So hitting them with this and increasing immune surveillance, it seemed to act as an augmentative agent to help with in both contexts, actually. So we don't know exactly which part was more effective, the neoadjuvant or the adjuvant arm, but doing it in both phases had wildly positive results. The primary endpoint was event-free survival. Secondary endpoints were overall survival and safety, and they were sponsored by Merck, Sharp, and Dohme. So this was presented, the preliminary results were presented at AACR in Chicago at the end of April, and in the plenary session. And this is what they showed, right? So this is just a diagram of how the trial was structured. I think the slides will probably be sent out later. You're welcome to review. We've kind of already gone over it. So what they found as preliminary outcomes, and again, I'm just going on what was presented at American Society of Clinical Research, ASCR, sorry. Anyway, whatever. Squamous cell carcinoma, the standard of care is highly morbid in these patients, particularly the radiotherapy is the origin of the majority of the complications and morbidity that accompany the treatment of head and neck squamous cell carcinoma. Our study showed a 21.4-month median event-free survival advantage in the treatment arm group. 21.4 months. That's not 2 weeks, guys. That's almost 2 years. This is incredible for cancer patients. Not only that, we found that complication rates between the 2 arms were quite similar, probably because the patients who were in the treatment arm, a higher percentage of them had a major pathologic response, meaning at least 90% of their tumor melted away when they did the resections after they'd had the neoadjuvant therapy. So what happens is these patients will have their neoadjuvant care or not if they're in the control group, and then they'll have their resections, right? And then I get their tissues as the pathologist, and I'm reviewing these. And I look and I will measure and count, and I'll look for scarring, and I'll look for deposition of giant cells and all of the things that accompany tumor regression in the context of treatment. And then I will measure and I will calculate a percentage of how much tumor remains. And what we found was that patients who had a major pathologic response, not complete, they still had, they still had 1 to 9.5, 9.9% of their disease remaining, so it wasn't complete. But they had enough that we could reduce their radiation doses later, or we could reduce their cisplatin administration, right? So they didn't have all of the side effects from that. We think that this is what leveled out the complication rates, because immune checkpoint inhibitors are not without their complications, right? You get autoimmune manifestations, pneumonitis, and organ inflammation, basically. Okay, so this was a wildly successful trial. It's not the only one. We've had quite a few closing out lately. So in short, to come back to my story and help you close it out, because we're running out of time here, we ended up coming full circle. So I waited for 20 years for this breakthrough that is on the slide right here. Starting in about 2019, we started to see papers, and I've started to see people, different CROs bidding on trials that are bringing immune checkpoint therapies back into its home, which is autoimmunity. It has been found in this paper that I've cited here that PD-1 expression levels correlate with disease activity in SLE, facilitating diagnosis, which means if we can find a way to measure this in a minimally invasive manner, hello, my cytologists, my friends who do the things I don't like to do. If we can find a way to measure this may be a shortcut to diagnosis, so we can save patients and their families that incredibly arduous journey through the diagnostic labyrinth that they are currently relegated to, right? Not only that, but it has treatment potential. The PD-1 pathway modulation has emerged as an actionable target for SLE treatment, and that's another conversation for another day. So it took 20 years, but we're finally starting to see some action on this. And fortunately for me, I was able to find some things for my daughter. We went off-road. We found some actionable targets, utilizing agents that we could access with minimal risk. And we put my daughter on a multimodality therapy. You would never know. You would never know. This is when she graduated from law school with my husband. And since then, she's gotten her master's and lives in Helsinki, so you would never know. So I didn't have to stand by her graveside. We used a multimodality treatment approach. We used a different lens. And that is my outcome. That is my proof of concept right there. So I don't need the Nobel Prize. I got that. There are lots of different lenses we can employ when we go through. And I want to encourage you to use all of that. Use all of the colors, right? Look at everything from every imaginable angle and collect all of that experience and all of that expertise, because you will use it. Life will give you the opportunity to apply the knowledge that you acquired using every other lens at some point. Just stash it away in that baggage that you've got on your back, because we all have it, and take it with you. And don't be sad that you have it, because in truth, our greatest successes are tied to our greatest challenges. Do not shy away from the things that scare you. When something scares you, run toward it, not away from it. Finding the right lens can be very different depending on the day, right? It's going to be different for every person in this room. Do not be afraid if the lens you need to pursue is different from the person sitting next to you. The person sitting next to you may think that your lens is garbage, but they don't have your eyes. So find the lens that works for you. It's different for everybody. It's also different in time. The lens that fits you today is probably not going to fit you in 10 years. If nothing else, you might need some bifocals, okay? And you might need stronger bifocals after that, I would know. It's going to change with your circumstance. No matter what you're going through, and it's going to change with the patient's circumstance. So the right lens to use with your students, with your patients, with the people you impact every day in your daily life is going to be different depending on your circumstance and theirs. It might be a traditional lens. It might be one that you can go pick up off the shelf at Walmart, right? But it might also require some innovation. You may need a custom job. Broke my glasses, had to go in yesterday and get custom lenses made. So my new glasses, ladies and gentlemen, made in 23 minutes yesterday. You may have to have some custom lenses made, but please don't be afraid to change your lens. If you look at fat necrosis of the breast at 100x, I promise you are going to overcall that as cancer all day, every day, or 40x for that. In those cases, find the right lens. 10x, nothing more. Okay. But if you're looking at an acute leukemia, please, for the love of all that is holy, get 100X or find somebody who does. Break out the oil. All right. Thank you for your time and attention. I want to say a couple of thank yous, if that's okay. I want to thank this training team. The training that you guys gave me as a resident here is world class. I can walk anywhere on this globe, on this beautiful rock floating space, and I can take my baggage with me, and I am equipped. I'm better than a Boy Scout, man. I feel like I could do anything. I should have a superhero cape. The training that you get here will equip you to do anything you want to do, and some things you probably don't to do. But take it all in, learn as much as you can. It's 4 years. And then what you do with it is up to you. So thank you to the teachers who taught me. And I hope that I will honor your legacy by doing well by my students. Thank you.
Questions, comments? And it would be nice to do a resident group picture with the speaker like we've done every year. So don't leave unless you have to. So we won't take too long to do that group picture. I see a lot of yours, which is really nice. I think the Zoom option is there, but it's being present is my motto. You need to show up in life, in everything.